بسم الله الرحمن الرحيم والصلاة على محمد وآل محمد. اللهم صل على محمد وآل محمد. محاضرتنا اليوم هي أسئلة مهمة جدا عن الضغط، وهاي المحاضرة تشمل oral question in hypertension. السؤال الأول: What respiratory disease causing hypertension? The respiratory disease that causing hypertension هو sleep apnea syndrome. What valvular disease replacement causing hypertension? Aortic valve homograft causing hypertension. What blood disease causing hypertension? Polycythemia rubra vera causing hypertension. What CNS disease causing hypertension? Head injury can cause hypertension. Subarachnoid hemorrhage causing hypertension. Was CVA usually in the first 1 or 2 days? Question number 5: What congenital heart disease causing hypertension is a correction of aorta? Question number 6: What endocrine disease causing hypertension? Endocrine disease causing hypertension are Cushing disease, pheochromocytoma, thyrotoxicosis, and in thyrotoxicosis you get the pulse pressure is high. Cone disease, aldosteronism, acromegaly, primary hyperparathyroidism, hypothyroidism, and hypothyroidism causing increased mainly diastolic blood pressure. Therefore, you get a narrow pulse pressure. Oral contraceptive pills, it's causing hypertension. Question number 7: What are the clinical signs in patients with hypertension caused by secondary hypertension caused by renal disease? الفيزيكال ساين اللي موجودة physical sign in renal disease causing hypertension, they are 8 signs. First sign: anemia. Usually anemia may reach 5 gram, and the patient got no shortness of breath due to the hemoglobin dissociation curve shifting to the right and making more oxygen delivery to the tissue. Second physical sign: earthy color. All these indicating chronic renal failure. Buffness of the face and the eyes, nephrotic syndrome, physical sign. Palpable kidney in the abdomen due to polycystic kidney disease, and hydronephrosis. Abdominal bruit in renal artery stenosis. Deafness in Alport syndrome, Alport disease. Phimosis due to stricture of urethra. And you do a PR for the patient with if you suspected cause of his hypertension is renal cause. Probably you find a benign prostatic hypertrophy, or you will find CA of bladder. Question number 8. Question number 7 we are talking yet is very important. You should remember it. Question number 8: What with hypertension? What a patient with hypertension? What the clinical sign indicating that the prognosis of this hypertension is poor? First of all, male patient, gender matter, male patient, because the female will tolerate hypertension. Female patient with hypertension is well tolerated by female. Youth, young people, black, especially American, African. Then obese patient with hypertension, prognosis is not good, is bad. Diastolic blood pressure more than 115. left ventricular failure, fundoscopy, retinopathy grade 3 and 4, stage. And chest X-ray, large heart, ECG, LVH with strain, where the last one is impaired renal function. These are the main important 10 causes poor prognosis in hypertension. Question number 9, what clinical signs in patient indicating that this patient got severe hypertension? Clinical signs of severe hypertension. The fourth heart sound, lub dub, 3 and 4 before systole you will get el fourth. It means a stiff left ventricle and the patient got LVH. You get fourth heart sound, tr, tr, not lub dub. Lub dub 2, first and second, while tr, tr, 3 sound you will hear. Aortic ejection click. And we said before that this is the valve. Opening of the valve for the diastole. This opening we cannot hear it normally. The sound of the opening of the valve is not heard by the human being normally, while closure of the valve we hear it. This is the first heart sound and second heart sound, whether it is mitral and tricuspid first and aortic and pulmonary is the second. Therefore, if you hear that opening of the valve in a patient, it means that this is a click, aortic ejection click, and ejection systolic murmur in the aortic area due to dilatation of the aorta, where signs of left ventricular failure, of endoscopy, retinopathy, grade 3 and 4. Question number 10, what are the lab tests and ECG and echo and chest X-ray signs indicating that the blood pressure is severe? General urine, if you found albumin and or granular cast, indicates severity. ECG, LVH with or without strain indicates severity. Chest X-ray, large heart indicates severity. Where chest X-ray signs of heart failure, a large heart, and there is a sign in the lung of a heart failure. LVH in ECG. How you define LVH in ECG? In ECG, you will look for R in AVL more than 13 small square, and R in AVF more than 20 square, and R in V5 and 6 more than 25 small square. And if you take an R in V5 or V4 plus the deep S in V1, if it is more than 35 small square, this is LVH. While the right ventricular hypertrophy is only affecting the leads in facing the heart, facing the right ventricle, which are V1 and V2 and V3 and sometimes V4. And we get a high R in V1 to V3 dominating, where dominating the S usually the S is dominating normally, and in right ventricular hypertrophy you get S, R is dominating, and the R wave is more than 3 to 5 millimeter tall. Probably we will find ST depression and inverted T in all these leads we talk about. Question number 11, patient with hypertension, what you ask him to do apart from taking drug. Ask him to reduce his body weight, stop smoking, stop alcohol, regular exercise, decrease salt intake in the diet to 2 grams per day, adequate potassium, and decrease the saturated fat, regular checking of blood pressure, and do all investigation required in case of hypertension. These are the patient, you should ask the patient to do this. Question number 12, in a treatment of malignant hypertension, what time needed to decrease the blood pressure and why? If the malignant hypertension is without encephalopathy, we should decrease the blood pressure over 2 or 3 days and not in the first day. And while if the patient got encephalopathy, I mean severe headache, visual disturbance, fit, epilepsy, coma, you should decrease the blood pressure within 4 hours, and you keep the diastole up to 110 and not less. And when decrease the blood pressure rapidly, it will cause a CVA in patient because of the poor cerebral autoregulation, and you should not do it. Don't use sublingual nifedipine because it causes a severe decrease in the blood pressure and might cause CVA and death. Question number 13, patient with hypertension and he is having juvenile diabetes with a proteinuria. How you treat? ACE inhibitor is best here, but if the patient got cough, you should use Arabs, valsartan, losartan, candesartan, and etc. There are more than 15 type of these blood pressure, and your target is less than systole less than 110, and the diastole is less than 80. And don't use beta blocker in this type 1 diabetes because it type 1 or even type 2, because it masks the sign and symptom of hypoglycemia. Don't use diuretic because it makes the diabetes uncontrolled. And don't use aldomate, centrally acting sympatholytic drug, because it causes postural hypotension. Question number 14, patient with hypertension, he got a heart failure. What drug you use? You should avoid beta blocker and calcium channel blocker, because calcium channel blocker is a negative inotropic, and you should treat him with ACE drug or Arabs and with diuretic. Elderly patient, question number 15, elderly patient, he got systolic hypertension. How you treat? Treatment is with the diuretic and with calcium channel blocker, long acting. It is called dihydropyridine amlodipine. Number 16, question number 16, a patient with ischemic heart disease and got hypertension. The best treatment here is a beta blocker and amlodipine, calcium channel blocker, dihydropyridine, long acting. A patient with long acting beta blocker, atenolol, usually we starting with a 50 milligram daily and increase it to 100 daily, not more. Don't exceed, because if you exceed, you get no benefit of its action, while you get more side effect. Patient with heart hypertension, he got AF or SVT. The best treatment here is beta blocker or calcium channel blocker in non-dihydropyridine, diltiazem, nifedipine, or verapamil. But verapamil is weak, is used for arrhythmia, yes, true, best, and while is not good for hypertension. Patient on cyclosporine and he got hypertension. How you treat? Actually, cyclosporine and tacrolimus, both of these increase the blood pressure in the patient receiving these two drugs, especially a transplant patient. Action is by inhibition of the calcium in uronine. Therefore, the best treatment is non-dihydropyridine, diltiazem, or verapamil. But these two drugs, it cause an increase in the cyclosporine concentration or level in the blood and make a lot of side effects. Question number 20, what are the indications of cyclosporine? Indication usually in transplanted patients and in severe rheumatoid arthritis. A side effect of cyclosporine, nephrotoxicity, hepatotoxicity, edema, tremor, gum hypertrophy, skin malignancy, lymphoma, epilepsy. A dosage in renal transplant 6 mg per kg per day. In rheumatoid arthritis, less than 4 mg per kg per day. And you should do blood urea and electrolyte and serum creatinine every 2 weeks for the first 3 months. And after that, you should do it monthly. We stop here, and we have 1 or 2 lectures more in hypertension. And thank you very much.